I'd like to introduce today our next speaker, Dr. Miriam Bredella. She's an MD and an MBA, professor and vice chair of radiology at Harvard Med School and Mass General. I spent quite a bit of time at Mass General for my training, so I can definitely appreciate the location and the position. She's a professor of radiology at Harvard Med School, vice chair for faculty affairs and clinical operations in the Department of Radiology at MGH, and also in charge of faculty-wide MGH-wide Center for Faculty Development, which is quite interesting. She's a PI on a Harvard Medical Research Investigator Training Program grant, where she trains and mentors clinical translational researchers across Harvard. And she's been elected to be a member of the NIH. Some of you have heard of the CTSA and the Translational Science Institute and Programs at NIH, and she's part of that. As well as she's actively involved in diversity and inclusion issues at MGH. And her research is focused on fat deposits in bone metabolism and their risks as they relate to metabolism and nutrition. And she's won several awards related to this, including President's Medal of International Skeletal Society. And with that, I will I'll hand it over to Miriam.
Great. Thank you so much for this kind introduction. I will share my screen. And I'm very honored and humbled to participate in this symposium and to honor Dr. Gambier, and I would like to thank Dr. Gold for inviting me. So I'm very excited to present some new data on the bone-fat connections, a little bit different what you heard so far. So there is an important connection between bone and fat, and both bone and fat cells arise from a common mesenchymal stem cell within bone marrow. And depending on the interaction of physical, chemical, or molecular stimuli, these cells can differentiate into osteoblasts or adipocytes. So our bones are composed of trabecular bone, which you see here, these little struts, and the space within the trabecula is filled with bone marrow. So we have hematopoietic or red marrow, which is red on the graphic, and that contains stem cells, which produce our red or white blood cells or platelets. And then there is yellow or fatty marrow, which you can see in yellow, which contains adipocytes. And fat within bone, so-called bone marrow adipose tissue or Bmat, is distinct from other fat depots such as white fat, your subcutaneous fat, visceral fat, or brown fat. And Bmat was long thought to be just an inert fat depot, just filling empty spaces that are left from bone loss without any specific function. But recent studies have shown now that Bmat is actually a secretory or metabolic organ that secretes hormones and cytokines, which then can impact skeletal homeostasis and energy metabolism. And Bmat also responds to nutritional challenges. Bmat is not distributed uniformly around the skeleton, but increased predominantly in arms and legs. And in a truly translational study in mice and men, actually it was in women, we defined two types of Bmat. So in the proximal skeleton, which the axial skeleton, the spine, the pelvis, or the sternum, or the proximal of long bones, there are specific marrow adipocytes which increase or decrease in response to environmental or pathological stimuli. Hence, we call this fat depot regulated Bmat or RBmat, and we found that it actually contains lower unsaturated lipids. It has a different composition. Then we have the distal Bmat, which is found in the extremities and distal parts of long bones, and this Bmat develops early after birth and is rarely depleted, meaning that it remains fatty and does not change that much under challenges. And this fat depot has been termed constitutive Bmat or CBmat, and we found that it has more unsaturated lipids. So marrow adipocytes can be quantified non-invasively using proton MR spectroscopy, which is considered the gold standard. Here you can put a voxel basically in any bone, and then you get a spectrum typically a water peak, which is from the red marrow, and then a fat peak from the marrow adipose tissue. You can calculate the area under the curve and get a lipid to water ratio. But using proton MR spectroscopy, we can also examine the composition of Bmat and quantify the amount of saturated and unsaturated lipids. So here we see a spectrum from the diaphysis, and you can see the saturated fatty at 1.3 ppm, and then the unsaturated fatty acids at 5.2 ppm. Important is that studies have shown that you have very low unsaturated fatty acids. That's the one that are also good for your metabolic health. There is an increased fracture risk, and we thought maybe this can also be an indicator of metabolic risk. You can also quantify marrow adipose tissue using MR, Dixon in and out of phase imaging, which is more robust and has the advantage that you can place multiple voxel in different parts of the anatomic region and get this in a single acquisition. On the paper on the right, we use dual energy CT to quantify marrow adipose tissue, and you can also then quantify bone mineral density, so BMD, all in a single examination. We found excellent agreement between marrow fat by spectroscopy and dual energy CT, as you can see here. But we also assessed the difference in BMD, so bone mineral density assessment, with and without the removal of marrow fat elements. And interestingly, the presence of marrow fat led to an underestimation of bone mineral density, and this bias increased with increasing Bmat content, which indicates that your BMD assessment by CT is actually influenced by Bmat, and that dual energy CT can actually provide a more accurate assessment of bone mineral density by taking into account the marrow adipose tissue, which is important, especially after condition with excess marrow fat, for example, after radiation therapy. So what are now the function of Bmat? This graphic provides an overview of the potential endocrine and metabolic function of Bmat. So bone marrow adipocytes can secrete local factors that directly impair bone formation, or they stimulate bone resorption, thereby increasing fracture risk. So Bmat expansion can be induced by high caloric diet, aging, or chronic caloric restriction, for example, in anorexia nervosa. And then macrophages within marrow adipose tissue can initiate an acute inflammatory response, which then leads to the secretion of pro-inflammatory cytokines such as TNF-alpha or interleukins that inhibit bone formation, and they can recruit monocyte precursor, which stimulate bone resorption. What's really intriguing is that these paracrine actions might also promote the growth of tumors within bone marrow, such as myeloid or lymphoid cancers or metastases. So we wanted to assess the role of Bmat and its role in metabolic risk and bone health in patients with type 2 diabetes, because these patients are very interesting. They have a high fracture rate despite having normal or even elevated bone mineral density. So in a study in patients with obesity and type 2 diabetes, we showed that bone mineral density was higher in patients with type 2 diabetes compared to non-diabetic controls with similar age, BMI, and sex. But patients with diabetes also had higher bone marrow adipose tissue. So it's not just if you have low bone mass, you have high marrow fat. In this case, they had high bone mass and high marrow fat. What's really interesting, the composition of their marrow fat was very different from the non-diabetic controls. They had more saturated lipids and lower unsaturated lipids, which I indicated earlier are associated with increased fracture risk. And we also found a positive association between marrow fat and HbA1c, which is a marker of insulin resistance and glucose control. So Bmat might not only be a biomarker for bone health, but also for metabolic risk. So we then wanted to study what happens to Bmat in obesity after you lose weight. So we examined adolescents with severe obesity who underwent weight loss surgery, sleeve gastrectomy. And we also studied a group of age and BMI matched control adolescents who were followed without surgery. They were just instructed to do diet and exercise. And we assessed Bmat of the lumbar spine by proton MR spectroscopy. And we also did QCT to assess volumetric bone mineral density. So here is a 17-year-old girl before and after weight loss surgery. She lost about 32 kilos, but you can see that her bone mineral density decreased from 183, which is actually pretty high, to 146, so a 20% reduction in BMD. So now let's see what happens to her marrow fat. So here you can see that marrow adipose tissue actually increased significantly 12 months after sleeve gastrectomy. So that shows that weight loss surgery impairs bone health. Here's an 18-year-old female runner with right hip pain. The radiologist in the audience probably see immediately that she had a stress fracture. But if you look carefully at the MRI, you can see that she has a paucity of adipose tissue and had a BMI of 17 and had anorexia nervosa. So one of the first study we did to assess marrow adipose tissue was actually in women with anorexia nervosa. And we interestingly found that girls or young women with anorexia nervosa had higher marrow adipose tissue in their spine. Here is a spectrum of a girl with anorexia and a normal weight control, and also in the femur, despite having markedly reduced body fat. And we also found an inverse association between marrow adipose tissue and bone mineral density and body fat, showing that Bmat is really distinct from other fat depots and underlies different regulations. So far we have examined Bmat in obesity, so chronic conditions of over and undernutrition like anorexia nervosa, or long-term weight loss after weight loss surgery. But then we wanted to examine Bmat after acute nutritional challenges. So we examined 23 healthy subjects, 13 men, 10 women. They were mean age of 33, and they were normal weight to slightly overweight. So they were admitted to our clinical research unit for 2 inpatient stays. So first, they came for 10 days for a high caloric stay. We'll talk about a little bit more what we did. Then they went home for 14 days to eat normally. And then they came back again for a 10-day fasting stay. They were admitted again to really not eat anything. So here is the study design. During the 10-day high caloric stay, they ate about 5,500 to 6,000 calories. The goal was to increase, to lead to a 7% increased weight gain. Then they went home for 14 days. We did not really prescribe a specific diet. They just ate regularly. And then they came back for 10 days where they only drank water and got some potassium, a multivitamin, and vitamin D. We performed MR spectroscopy to look at marrow adipose tissue of the spine and femur. We also did MRI to look at body composition and specific abdominal fat compartments. And we did whole body DEXA to look at whole body fat and lean mass. And I actually did marrow aspirations, and we isolated marrow adipocyte and marrow serum to look at inflammatory markers. We also performed real-time qPCR of gene expression of marrow adipocytes and looked at inflammatory markers that you can see here. So not surprisingly, there was an increase in weight during the high caloric visit. It was only 6.3%, so slightly below the 7% that we targeted. Then patients lost weight again, about 2.7% of their body weight when they went home to eat normally. And then during the fasting, they lost another 8.8% on average. So they left the study lighter with less weight. Similar findings were seen with all the adipose tissues and lean mass. Again, there was an increase during the high caloric visit, and then a decrease during the stabilization period, and then a further decrease during the fasting period. Now let's take a look what happened in marrow adipose tissue. Interestingly, in the lumbar spine, there was an increase, and the femur as well. When they went home, there was a marked decrease, actually lower to where they started. And then in the spine, it went up again. So similar what we saw in the women with anorexia nervosa, while in the femur it went down. So these are, again, these 2 types of Bmat, the constitutive and the regulated one, which behaved in a different way. So here is just an example of a subject. This is at baseline. You can see this is from the lumbar spine, the water and lipid peak. Then there was an increase after the high caloric period. Now this is again, C here is at baseline when they came back for the stabilization, for the fasting visit. And then there was again an increase in marrow fat following the fasting. Now let's take a look at the marrow adipocyte gene expression of inflammatory markers. So for resistin, which is an inflammatory marker, we didn't see anything in gene expression of the adipocyte, but there was a significant increase in marrow serum after the high caloric diet and a significant decrease during fasting. If you look at the other inflammatory marker, there was a significant increase after the high caloric diet, and either no change or a decrease after the fasting. TNF alpha significantly decreased. So this suggests that although Bmat increased during high caloric diet and fasting, it probably has different underlying mechanism just looking at the inflammatory markers. So now we're switching gears a little bit, but as I alluded earlier, there is maybe these inflammatory reactions that are going on in Bmat might play a role in cancer development or progression. So Bmat is actually now recognized as a contributor to multiple myeloma development and progression by, again, affecting myeloma cell metabolism, immune action, and inflammation. And as I said earlier, Bmat can inhibit osteoblasts, and also now studies have shown that it can inhibit anti-cancer effects of immune cells and support osteoclast and myeloma cell development. And we have actually found higher Bmat in patients with MGUS, which is a precursor to multiple myeloma, compared to matched controls. And Bmat might actually represent a new target for anti-myeloma therapy. The last study here is, this is another example of systemic crosstalk between tumors and the bone marrow, in this case in lung cancer and bones. In this translational study, we found that lung tumors can actually remotely activate osteoblastic cells in bone marrow, even in the absence of local metastases. And they can supply tumors with specific neutrophils, which promote cancer progression. And here in this mouse model of KRAS positive lung cancer, you can see here on the right, there was higher trabecular bone compared to the control mouse. And I think the reason why this ended up in Science is that we could actually show this in humans, that patient with a certain type of non-small cell lung cancer had actually higher bone mineral density compared to the controls. So in summary, there is an important connection between bone and fat, and Bmat is a dynamic fat adipose. We are just learning more about it. It can secrete hormones and cytokines. We can quantify it because the content and the composition using proton MR spectroscopy, and can actually quantify changes during short and long-term nutritional interventions. We found an increase in Bmat following short-term high-caloric feeding and fasting. However, our marrow adipocyte gene expression studies showed that there's probably a different underlying pathophysiology. The high-caloric feeding produced an inflammatory response within Bmat, and this rise in inflammatory markers might actually contribute to the long-term sequelae of high-caloric diets and the metabolic syndrome. We did not find an increase in these inflammatory markers in Bmat after fasting. In fact, there was a reduction in marrow TNF alpha. And what is really exciting in this topic is that these cytokines from marrow adipocyte might play a role in cancer progression and may represent new targets for anti-cancer therapy. Would like to thank the NIH for funding our studies, and would like to thank you for your attention.
Okay, thank you. Excellent talk from Dr. Bredella. Very interesting topic. We are looking for any questions from the audience. There is one here. Do you think that there will be BMD loss with anti-GLP-1 therapy for weight loss?
That's a great question. Depending on the amount of weight loss, probably, because we have shown now in several studies, not just in bariatric surgery, where the mechanism might be slightly different because there are hormonal changes or anti-absorption, but we have also shown it with intermittent fasting that there are these long-term changes, that there is probably bone loss.
Great. It was such an interesting talk. I haven't personally, I've been in, research for a while. Just haven't even heard much about this topic. Um, are there any other, since our talk is, interdisciplinary today with respect to imaging as well, were there any other techniques to image the BMAT? You were talking about MR and MR spec today, mostly from what I saw. Were, molecular imaging approaches or fluorescence or well, maybe not fluorescence, the best idea, but some other techniques?
No, just the dual energy CT is, we heard a talk earlier about the photon counting CT. We haven't tried that yet, but the dual energy CT was actually cool because you can do two things in the same study. You can assess bone mineral density and marrow adipose tissue. I would be interesting to maybe use photon counting CT and see how that would be able to quantify it even more accurately.
I guess other than the cancer connection, it seems like you're, in this, it's this pretty new area, it seems to me. So what were you guys thinking of different types of research directions? I was just curious how you guys are thinking about the problem, because you're talking about metabolism, cancer, so many things here.
I think most studies, and we have done, I had like 3 or 4 NIH grants, all focusing on marrow fat. We had one very large one interdisciplinary study on marrow fat with different institutions, where we really found what's the function of marrow fat. We had this grant for over 10 years. And we did a lot of animal models, humans. Our center was responsible for the human studies where we did the nutritional interventions, but we also found, for example, that marrow adipocyte can secrete adipokines and adiponectin, which was a major breakthrough because 10, 15 years ago, people thought marrow fat just fills spaces. So we were more interested in the metabolic aspect, and adiponectin is an important cytokine for metabolic health, but also bone loss, because the anorexia, we do a lot of research in anorexia nervosa, and it was just quite striking that these women who have no fat anywhere else had so much fat within their bones. So we started more in the direction, because it was funded by NIDDK, for metabolic disease and bone health. When we started to go into the cancer area, we were told this is NCI territory, stay away, but we're doing it anyway. And I was actually approached by our multiple myeloma group. So we're doing a lot there, because now marrow fat is actually thought to be really important for the progression of disease. So we're now doing some studies in patients with multiple myeloma.
So with respect to the anorexic patient, you were saying that, I think you were trying to make the case that they did not have body fat, but they still had fat in the bone, and that was contributing to some of the health problems that they were.
Well, the interesting part is, so women with anorexia nervosa who are not extremely sick, they have a lot of fat within their bones, and maybe this is part of the body to hang on to the last resort of energy, because you need marrow fat for bone growth also, and maybe it can supply some type of energy. But if you have for example, cachexia, where you are so thin, actually the marrow fat gets metabolized. That's really in the large. You just often see this in cancer cachexia. If someone is really, really cachexic, and then this marrow fat gets actually replaced by this gelatinous fluid, which looks necrotic on histology. That's called serous atrophy of bone marrow. So the body first increases marrow fat, probably to hold on to something, and then if the patient is so thin and cachexic, then this last marrow fat then also gets metabolized, and that has a really, really bad prognosis. We see this in severe cases of anorexia, or in cancer. We often see it in cancer, and has extremely bad prognosis.
Very, very interesting talk. We really appreciate it. We are unfortunately out of time. I don't see any other questions, so thank you. We were going to move on. Really enjoyed the talk. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.